Hi friends, good evening. I'm Dr. Ashutosh Gupta, and let us talk about polyhydramnios, right? So the baby remains in a pool of water, which we call as an amniotic fluid, and therefore the amniotic fluid would have a range. So usually the amniotic fluid is something around 14-15 centimeters. So whenever it is greater than 24 centimeters, which we calculate by doing an amniotic fluid index, right? We identify the amniotic fluid in all the four quadrants of the uterus, and then whenever the amniotic fluid is greater than 24, we identify it to be polyhydramnios, right? So polyhydramnios on its own can definitely have its own sort of a complication. So probably we need to identify the reason behind this polyhydramnios, and then probably how do we manage the polyhydramnios, right? Okay. So the polyhydramnios can happen in both DADC twins as well as DAMC twins. Okay, so probably we are today we are having two cases in which in both the cases we are having polyhydramnios. So probably let us first see the case, and then probably we'll discuss how do we what is the probability etiology and how do we deal with this thing. Okay. Now this is the first case. So this is a DADC twin. Okay, so the AFI of the first baby is 16 centimeters, right? And the second one is 23.8. So it is a polyhydramnios. Now what we have done is that we have looked around for the baby, and then but you look around in here. This is the marginal and the velamentous cord insertion. So the umbilical cord is inserting just into the boundary, right, into the edge of the placenta. So this is a velamentous cord insertion, right? And then we can see the intervening membrane between these two babies. So this is a velamentous cord insertion. So this is leading to polyhydramnios in the baby in which it is happening. This is single placenta anterior. So this is a DAMC twin, and we can identify the thin membrane, but the umbilical cord insertion to the placenta is the same, right? So you look around, and this is marginal and the velamentous cord insertion, which is entering just adjacent to this membrane, right? So it is behaving like an AV fistula, and it is a velamentous cord insertion. So this is happening in a DAMC twin, right? And this is how it is. So yeah, so this is the membrane. This is a thin membrane, and then we can identify the vessels entering into the placenta. So if you look around for the amniotic fluid, the first one is 16 and second one is 24. The possible etiology could be gastrointestinal. We can have a brain abnormality, musculoskeletal. We can have some chromosomal abnormalities, infections, and we can have anemia and twin to twin transfusions, idiopathic also. The reasons for polyhydramnios can vary hugely. So this could be starting from the brain. We can have ventriculomegaly, inability to swallow. We can have a cleft lip palate. We can have gastrointestinal abnormalities. We can have a small stomach. We can have a tracheocecal fistula. We can have a small intestinal obstruction. The proximal the obstruction it is, the more severe and the earlier the polyhydramnios sets in the gestational period of the fetus. And then we can have kidney abnormalities. We can have Bartter syndromes. We can have congenital nephropathies, in which the fetus kidneys are they lose the ability to concentrate the urine, and therefore they are salt losing nephropathies. We can have nephrotic syndromes. We can have fetal echinacea and a lot of things across fetal echinacea, FADS, and we can have aneuploidies. Then comes the infective part. So in an infection also can lead to this all these things. We can have a parvovirus leading to fetal anemia, and therefore we can have the polyhydramnios. And in a DAMC twin, we can have a twin to twin transfusion syndrome. So we can have a TTTS and we can have a TAPS, uh, twin anemia and polycythemia syndrome, right? And but then this is the case which is very unusual. So meaning thereby that in both the DADC and DAMC, the placentas are the different in DADC and placenta is same in DAMC, but the possible etio pathogenesis for a polyhydramnios is almost the same, that we are having a velamentous cord insertion of that umbilical cord into the placenta, and therefore the vein gets pressed upon and the arterial supply keeps on continuing with it, and therefore it might behave like an AV fistula leading to polyhydramnios, right? And so we are having this DADC, which is genetically different, and DAMC, which is genetically same almost for all practical purposes, and therefore we are dealing with polyhydramnios in one of the twin. and in less than 28 30 weeks we can use the we can have the advantage of having indomethacin. And so we do have some sort of an titration of the doses, and then we decrease the doses of the indomethacin as the gestational age of the baby advances. And then we keep a close watch for the premature closure of ductus arteriosus. We try to look around every weekly. We try to look around for the flow across the ductus arteriosus. And in less than 30 weeks, we've identified that if we withdraw the indomethacin, the premature closure is usually reversible. So we really don't continue more than 30 weeks. And if need be, we might need to do the amnio reduction. So this is how we probably look around for it. And this is how we can manage the altogether the pregnancy. And but the thing is this, since it is a velamentous, what happens is this, that if you drain the amniotic fluid, since the basic pathology remains, so it is almost going to fill up again within a span of 3 to 4 weeks, right? So that is the basic sort of a pitfall with this. So it is always better that probably we do a medical management of the polyhydramnios in both the dichorionic and monochorionic pregnancy, and just we wait for the good results to happen. So if somehow we are able to get on to 30, 31 weeks or 32 weeks, and then if the need arise, we might put the needle and take out the amniotic fluid so as to give some relief for an acute polyhydramnios to the mother, because you identify that in both the conditions we are having two fetuses. So one baby is having 24 and the other one is having 16. So for all practical purposes, we are having an AFI of 40 centimeters as a singleton pregnancy. So definitely there would be some signs for an acute polyhydramnios to the mother. So probably we need to see for the acute symptomatology of the acute polyhydramnios to the mother, and probably we need to um, do something for that, and probably need to and drain out the amniotic fluid so as to relieve the mother from acute polyhydramnios. Okay, thank you very much for your patience.